Yeah, I know there. I know at least Beth said that she would probably come on late because she's at a doctor's appointment with her husband. But I'm assuming that you kind of keep track, and if somebody wants to come in, you let them in.
Yes.
Okay.
All right, so I'll get going. My name is Mintonen, and I am on Nantucket, NAMI. I work for NAMI on Nantucket, primarily have been doing work in substance misuse prevention, but also dual diagnosis and general mental health. And I will pass it on to Jackie, just so you can make sure everybody knows who you are.
I'm the executive director of NAMI Cape Cod and the Islands, and that includes NAMI Cape Cod and the Islands on Nantucket. And we've been very, very active on Nantucket. I spend a great deal of time dealing with Nantucket things. And we have a staff of 2 people, Sue being one of them, and I'll pass it over to Suzanne in a minute. But the exciting news is on Tuesday, hopefully, I'll be on Nantucket with some people from Gosnold, and we will actually have a physical office on the island that we're sharing with Gosnold. So that is going to up our profile on the island even more, I hope.
Hi, Suzanne Franzuto, NAMI on Nantucket. I work primarily in mental health education, support groups, and advocacy.
I'll go to the bathroom real quick. I have somebody waiting, but so nice to meet you over here.
Who would like to go next? Jackie Edwards?
I am a parent on Nantucket. I've been here over 50 years, and I've been very interested in seeing that mental health gets the attention that it needs.
Sarah Anton.
Sorry about that. I am Sarah Anton. I'm the Director of Development at Gosnold, and I'm so happy to be joining this. This is my first advisory meeting, and while I don't have a clinical background, I have a background in nonprofit administration and fundraising. So I'm just excited about, as Jackie mentioned, I'm excited about Gosnold really enhancing and expanding their programs on Nantucket to address substance use and the co-occurring disorders. So thank you. And I'll let Erin go now because she's the other Gosnold person that's on the call.
Great.
Well, I'm the outpatient director in Centerville, Nantucket, and Falmouth for Gosnold.
Mary? How about Christine?
Hi, good afternoon. I'm Christine Montero. I am the mental health coordinator for Children's Cove, and Children's Cove is the child advocacy center for Nantucket, Martha's Vineyard, and Cape Cod. Myself and Jacob Stapleton sort of switch off attending this meeting, and in my role, I help to make referrals for the children and teens we see and work closely with the mental health providers on Nantucket.
Thank you. Brooke? Oh, there's 2 Brooks. Brooke Moore.
Yeah, that's fairly unusual, actually, to have 2 Brooks. I'm Brooke Moore. I have training in social work. I have an MSW, not in practice, but I currently serve as the vice chair of the Nantucket Affordable Housing Trust and the chair of the Nantucket Council for Human Services. So this is taking care of people is my passion.
Thank you. Margareta.
There's probably not more than one Margareta in the room, right? It's always been a mouthful. Margaret Andrews, Executive Director of the Community Foundation for Nantucket and on the steering committee of the Behavioral Health Initiative.
Thank you. Chris.
Good afternoon, everyone. Chris Glowacki, I'm the Vice President of Strategy and Community Development at the hospital, and also on the steering committee for with several people here for the Community Behavioral Health Initiative.
Thank you. And another, usually the only one in the room, Jericho.
Yeah, I tend to have an easily recognizable name. I'm Jericho Mealy. I'm the Director of Human Services for Town of Nantucket, and I am also on the Behavioral Health Leadership Group with Margaret and several others here.
Thank you. Mr. Pittman, Chief.
Good afternoon. I think it is, yes. I'm the police chief in Nantucket. Was interested in hearing Brooke Doyle discuss the future of mental health and behavioral health in Massachusetts to some extent. I know there's a lot of changes coming in the way law enforcement interacts with behavioral health cases in the field. We certainly want to be on top of that and help in any way that we can. Unfortunately, we see, the tragic part of behavioral health issues being untreated, and hopefully we can reverse that.
Thank you. Bint?
Yes, hi, I'm Bint Rustad, and my role is more of a support role in terms of we have a nephew who's been involved in the system for the last 6-7 years now, I think it is. And I also have a background as a counselor, social worker in the criminal justice system. So here I am.
Amanda?
Hi, everybody. I'm Amanda, the clinical director at Fairwinds. Nice to see you all.
Thank you. Oh, Mr. Bridges just popped in. Do you want to introduce yourself?
Hi, sorry, I was having a hard time logging in. Hi, Jason Bridges, executive director at Fairwinds, and on the select board here on Nantucket.
Thank you. And Sarah E.
Hi, my name is Sarah Ellis. I'm a resident of Nantucket and have personal experience with mental health problems and diagnosis as bipolar. I just wanted to listen in as I've been following in some publications a little bit of the mental health initiative.
Great, thank you. Mary, did you want to introduce yourself? Okay, Brooke Doyle.
I'd
Do you
like
want
to
introduce?
Yeah, I'll introduce Brooke Doyle. I'm very excited. I've actually met Brooke Doyle once or twice. She may not remember. It's a few years ago prior to this position that she holds. But Brooke Doyle has had 30 years in the field of mental health as a clinician, a supervisor, and an administrator. And that's giving her both sides of the story, the clinician part and also the administrative background. And her experience has been both in the public and private sectors. She's been a champion for the mental health parity, which we all know hasn't really yet been enacted fully. And also she's done a lot to, and I think this is where we're at right now, of mental health access for everyone. She's also had experience, which is always near and dear to me, coming from the Cape and even somewhat on Nantucket with homeless issues. So it's a great pleasure to welcome Ms. Doyle, who was appointed to this position, maybe a couple of years ago, and she is the commissioner of the Department of Mental Health for the state of Massachusetts. So welcome, and thank you, Brooke, for coming.
Thank you so much. I appreciate the invitation. I just to acknowledge and be fully transparent, this is my favorite subject to talk about. So I accept every invitation to come and talk about this topic. It is the thing I'm truly the most excited and still extremely passionate about. We were chatting before the meeting officially kicked off that it is true that the pandemic has slowed some of the effort to get the roadmap launched, but it did not deter us. And we are continuing to make steady effort to get this fully launched. So I just want to acknowledge that the development of the roadmap and the reforms that are highlighted in this have been under discussion for some time now. And some of you may have participated in some listening sessions that were held. I do remember meeting you, Jackie. That was when we were doing the ACCS, the Adult Community Clinical Services stakeholder discussions.
Yes.
And to me, the important part about what we're talking about today, it does go back to those points about access, but it also ties into the points that we had talked about with the adult community clinical services stakeholder discussions, which is truly about making sure that people have access to the right level of treatment when and where they need it, meaning in the community. That's really what we want to see, is that the community services are robust and comprehensive and complement each other. So since I did hear that you all did receive the slides in advance, I'm going to just quickly walk through a couple of key points in the slides, and then I'll take them down so that we could have a more open dialogue if that works for all of you. I find that the opportunity to have open dialogue actually helps to answer what those local questions are that you all may be wanting to field. And there may just be points that are high level in the slides that don't quite get at what's really of concern or most interesting to all of you. So I don't want to use the whole time to just read through slides, if that's okay. All right, I'm going to share some slides and we'll just do this part really quickly. All right, and can everybody see this? Okay, great. Let me just make sure this is on slideshow. Beginning. Okay, can you see the next slide now? Is it advancing? It didn't advance? Okay. Is this working better?
Yeah.
Okay, we'll just stay on this view then. All right, so as I started off saying, we had some listening sessions back in 2019. Pandemic hit, and we weren't able to be as inclusive in the discussions about where we were going with this because people were addressing pandemic at the same time that we were doing a lot of the development work for this. But we did continue all of the development work along the way, and then had some public sessions this past spring to advise about where we are going with this. And that's where these materials are referencing and were developed for. So the bottom line is we did this all because we know that individuals and families don't often know where to go or what's available to get the kind of behavioral health services that they are seeking. And then sometimes when they do get to wherever they're advised to go to, they find that their insurance isn't accepted, or that it isn't in fact the right place for them, because they don't often have both addiction and mental health in the same treatment environment. That often leads people to the emergency departments, or worse, getting first responder responses. We heard from the chief just a few minutes ago. And then obviously we want to be sensitive to the needs to provide culturally competent care, which are often also hard to find. As I mentioned, the pandemic came to all of us. We were all chatting a little earlier about vaccination and boosters, and it's great to hear that so many people have made the commitment to getting vaccinated and getting your boosters done. And I just want to acknowledge that investments have been made in behavioral health services as well during this pandemic, both to support telehealth, but also to support the ongoing delivery of services. We appreciate that providers have been continuing to provide direct services to people throughout this pandemic, whether it's through telehealth or in person. So where we're going with these reforms are a single point of access. So what we've called the front door will be a single point of access. We're envisioning what will functionally have multi-channels, or the ability to call, text, or use a web entry point. We want to make it as easy to access as possible. And by having a single center or call number, it simplifies. You don't have to keep track of multiple different numbers. If you're not sure which service you need or whether now's the right time, all you have to do is call this one number and then they will connect you to the right place at the right time. Outpatient is the focus of these reforms. You know, a lot of people have asked what we're envisioning that we're rolling everything in. I want to be clear that these reforms are building on the network. They're not replacing it. It's important that we acknowledge that all of the providers who are out there today will continue to be able to provide services going forward. So these services that I'm describing are either modifications to the network or in addition to the network. I just want to be clear. A lot of people were nervous that we were going to be disrupting the whole system. These are modifications or building in something new that doesn't exist today. And one of those new things that doesn't exist today is urgent care for behavioral health. So I'm really excited to say that we're building in urgent care for mental health. And it's really important that we have this because we want to encourage people to be able to use community locations instead of emergency departments where it's safe to do so. In order to achieve the goals that we've set, we understand that we have to advance health equity to make sure that we're reaching people who we've had otherwise not always been able to reach. We need this to be literally covered by all insurances, not just some, and certainly not just the payer system. I mean, the public payer system, excuse me. We're broadening the public payer system, though, to include support titles that they haven't always included, which are independent licensed people in the fee-for-service category. And we also will be expanding coverage for certified peer specialists going forward. And that will get picked up through the Medicaid waiver that will be going in very soon. We're encouraging workforce diversity and competency in diversity. One of the things that some of you may have seen, there's been a huge, huge recognition of the need to develop the workforce, and the legislature has recently passed some ARPA funds to support what they've broadly called behavioral health pipeline development, meaning training and support resources for loan repayment, not just at the highest level professional titles, but direct care as well. So I'm really excited that there's recognition of the need to make these investments and that substantial amounts of money are going into that. This slide just is a quick illustration that centralized front door, or the single call line that I've talked about, is different than information and referral. This is really one of the key changes in these reforms. The intention that we have here is to provide triage and navigation. So it's an actual service, not just here's a list of numbers that you can call. There's actual linkage to the service with somebody who will stay with the help seeker and make sure that the resource that they connected them to actually was the right resource. So there will actually be follow-through checks as well. As I talked about the building upon part of this, one of the things that we understand is a lot of people get their behavioral health services through primary care, sometimes through other medical environments like community health centers. So there's also investment to help build out that capacity and to make sure that that capacity is as comprehensive as it can be for that environment. With that, we're going to be releasing a procurement for what are called community behavioral health centers. And the community behavioral health centers will function as a regional hub. They'll tie into the access line and they will become how the region, so there'll be identified regions, can have a 24/7 access point in the community. So part of the community behavioral health center will be to be that location of urgent care. There will be a very high bar for access, including the delivery of evidence-based practices, integrated treatment, and cultural competency. The intention of the CBHC is to provide treatment across the lifespan, youth, adults, and older adults. So I won't go into this slide again. It basically just describes that, again, this concept of a regional hub, that there will be a requirement that this is supported by the public payer system, but it will also have tie-in to the commercial systems as well. The CBHCs have certain principles that we've built into how these will be managed and operated. I think the key point here is, in addition to providing timely access, this goes back to the point in that first slide about the importance of integration across behavioral health. We often think about integration meaning between primary care and mental health. Here we're talking about the integration of substance use disorder treatment and mental health treatment. So the intention is to provide them under one provider type. We talked about how this will provide the urgent care component. Crisis care will also be available through these hubs. Telehealth as a tool will be continuing. In that early slide, we talked about telehealth becoming an important tool during the pandemic, and we envision that that will be continuing going forward. It's important that we also acknowledge that we understand that we have certain special populations who we need to make sure that we're attending to, and they can sometimes be viewed as difficult or complicated. And the CBHCs will have requirements that they need to provide access to these special populations. And Chief, you had talked about people who have criminal justice involvement. Our intention is that there will be special attention for people who come to the attention of a first responder, and that they can actually have both same day access, but also to understand that sometimes people need multiple attempts at engagement before it might work. And some providers, because access has been so tight, have had to have limits on how they keep cases open. And some providers have had to have what has often been operationalized as a certain number of missed appointments, and then the case is closed. And the intention here is that we will continue to keep your case open and to continue to try to engage, even if the person needs multiple attempts at that engagement. I spoke a little bit about primary care integration and where we're going with that. In terms of advancing health equity, we're talking not just about language access or interpreter access, but also to make sure that the workforce is reflective of the community that they're serving. in order to achieve what we're talking about, we understood that we needed to put some simplification in place in order to address some of the reasons that people have not always either as licensed professionals put themselves on panels with insurance, because they're often, what we've heard is that people are unable to go into a panel if the administrative requirements exceed their capacity. And so we're looking to make some administrative simplification where credentialing could be easier, where you don't have to have as many contracts, et cetera. Want to acknowledge that some special population needs with youth. It's our intention that all youth will be able to get treatment at the earliest point possible. Our goal here is to provide as much service to people as early as possible, and to really improve the likelihood that over time, their symptoms become less and less acute or less impairing to their functioning, and that they achieve their goals that they're setting for themselves as they're developing and achieving milestones like academic performance and moving into young adulthood and jobs and relationships, etc. So we are moving forward with our timeline. I just want to let you know where there will be some things happening very soon. We are in procurement mode, so I can't really speak to exact dates that things will happen. So I just want to acknowledge that things are in fact moving forward. And then I have a couple of slides that I'm just gonna highlight here, and then I'll take them down. One of the things that I wanted to just touch on with this slide here, the importance of having both the structural support with the treatment services. There's going to be adjustments to the payment model to make the delivery of service more flexible and easier to match to the individual's needs. So there's some movement away from the fee-for-service model of payment. And that can't be stressed enough as being really critical to the success of these changes. What we see sometimes now is that providers, because of the way that payment is structured, have to do therapy or medication management in certain ways, and they're less able to make good valued use out of other titles that can provide support to the team-based model. So this gives the provider some flexibility. All right, I'm gonna stop sharing. And just, I'm gonna stop sharing the slides, but was hoping that we could use the remainder of the time to walk through any questions or points of clarification that you all may want. If I need to put the slides back up, I certainly will. So anyone who'd like to open up the discussion, I don't know if you have any meeting rules about how people present themselves for discussion. I don't mean to change any meeting rules that you might have.
Brooke, this is Jackie Lane, and I do have one question. How does this, I know we're looking for the single entry point and the single number for people to get where they need to go. How does this, and this goes a little bit back to what Chief Pittman was talking about, I think. How does this relate to the system that we have right now with emergency services? On the Cape, we use Bay Cove. On Nantucket, Bay Cove is subcontracted to Gosnold, I believe. And we have been pretty much pushing the model of meeting the person where they are, going out into the community often, so to avoid the emergency room, which we know is the most expensive thing and not a great place for anyone with a mental health issue. So how is the emergency service piece going to change? Is there still going to be outreach into the community? How does that work with your single point entry?
Great question, Jackie. So we are actually building out the specs now for that, how that will connect in the way that you're describing. But you're absolutely correct that the intent of these reforms is to strengthen the crisis delivery system and to make it much more community-based than it is today. So there will be an investment both in the crisis service itself, but also in the integration with the CBHC. So there's going to be not just as it exists today, where there's a parallel track for your outpatient system and your crisis teams. Literally, there will be a requirement now that these are going to be integrated. And so it might look a little bit different from a contracting point of view, depending on the region. And there may be some special unique features of the region, but the providers will have the opportunity to propose how they want to meet the needs of the region that they're covering. And so what I want to stress, though, is that there was recognition that over time, the crisis service as it exists today was less and less able to do that community-based work that you're describing. So the investment in the community-based work is what will be changing going forward, along with the ability to operate a regionally centered crisis support system, meaning crisis beds for youth and adults. So it's not just the mobile capacity, but it also ties into the urgent care capacity. So appointments can be made for people at real-time access. And then also that those crisis interventions that are done as part of outreach and in the effort or interest of trying to divert from hospitalization wherever possible, that we're taking full advantage of the full complement of the resources in the team, including, for example, peer support, which sometimes can be a huge help for people while they're responding to reducing the acuity or reducing the crisis. Sometimes people need different types of support. I also just want to highlight that an important feature going forward will be the emphasis on using our co-response teams as well. So the department has made an investment in co-responder models for diversion from arrest. And so the intention here is to try to really use this network along with some of the existing response teams that we have out there. So we're, like I said, we're not eliminating or replacing, we're really giving new tools to people to use.
All right, could we do a scenario? Because, you know, we get those phone calls at NAMI. People say, all right, we're in crisis. My son or whomever, I'm picking on men, I guess, that he's having a mental health issue. We're afraid of him. We don't know what to do. And at this point, there are like two choices. Well, first of all, we could try to get, in our case, VACO, to go to the location, but there could be a danger element depending, or we can say, call 911, tell them it's a mental health crisis. And we have trained about 200 officers on the Cape in mental health first aid training, CIT training, and they've been, you know, it's been pretty good. All right. And so we have that call. Would we still do that same thing? And then what would the police actually do? How would it be a different thing? Suppose VACO and the police respond together, which is often the case, depending on the danger and so on and so forth. So, all right, so we get that response, and I assume that response would still be a legitimate response or not? Or are the police kind of out of it? I'm trying to figure this out.
You know, Jackie, you're bringing up an important point, and to be, you know, fully transparent, there isn't a one size fits all to what you're describing. It really is very situation dependent. It is also very community dependent. Some communities have developed or have more advanced behavioral response teams than others. And so it really does depend on the development within that community, but also the circumstances that are being presented. We want to support as much investment in the co-responder models that we can. So in addition to training for officers, the department also can make grants for co-responders that can be associated with the police departments or the first responder teams themselves. So that's something that we want to definitely encourage as much development in as possible. We have available funding for different or new opportunities for people if they're seeking them. And so just to concretely answer your question, what we want to do is to make sure that there's a 24/7 community-based option if it's safe to bring the person into a community-based location. If the situation is unsafe, then we're not envisioning that emergency departments go away. We understand that they still provide a vital function, particularly if the situation is unsafe.
The other question, we at NAMI, when somebody calls in that kind of a situation, and we all agree that probably BACO could handle it, then the next question we ask, what health insurance do you have? Now, I think this is going to address that issue.
Absolutely. That's one of the important policy changes here. So our intention is that all of this service for these both access line services and crisis response services are available to any resident within the Commonwealth, that we will no longer have to differentiate whether you have this type of insurance or that type of insurance. And if you have this type of insurance, you can only go to the emergency department. So this is exactly what we're trying to correct for. I noticed that Brooke, the other Brooke, has her virtual hand up.
Sorry, took me a while to find them. I have so many questions. The first is, you're talking about regions, and I'm wondering how Nantucket falls into the definition of a region. Our geography is obviously unique with Martha's Vineyard in that regard. That would be my first question.
I appreciate the question. And if we weren't in a procurement development mode, I would give you a very clear and direct answer on that. But because we're actually in a procurement phase right now, and that would be a violation of procurement law for me to give detail of something that might be really pertinent to the bid itself. So obviously our intention is to make sure that we continue to cover the Cape and Islands. So just want to acknowledge that. I would be more direct if we weren't in a procurement phase. I'm sorry.
Yeah, so probably my other questions fall into that as well. Do you envision this as physical spaces, buildings, new buildings, or new organizations, or are you imagining are existing organizations responding to the procurement?
So that's a really important question, which, like I said, will likely be very community driven, that the bid will specify what the program specifications are, and how each community chooses to organize themselves for response to this will likely reflect some things that might be very specific to that particular community. So there's definitely room for communities to shape how they would meet the performance specifications. So the bid will very clearly lay out all of those specifications.
And then, sorry, one last question. The cost of the cost of hiring and retaining people to execute the work on Nantucket is astronomical with our housing costs. And is there room for different funding rates based on that could account for those dramatic differences for the Cape and Islands versus the rest of the Commonwealth?
So there will be a standard rate for the CBHC and the services, the crisis services, and so forth. But depending on how the bidder chooses to respond to the bid, there may be partnership arrangements within that financing structure. So it's the rate models themselves will be standardized, but how, again, it gets back to how each community shapes the response. So it's a little hard to give you a more specific answer for that, because there will be standard rates, but there may be, a bidder may choose to respond to the bid with a partnership arrangement, in which case there would be a single point of accountability, but there might be ways that they provide partnership subcontracting that looks different or has different rate modeling in it. It's hard for me to answer that very specifically without violating procurement laws.
Okay, thank you.
See, Mary has her hand.
Am I Mary that you're referring? Oh, my name's Rachel Merriweather, but it's coming up funny. Okay. I was like, who's this Mary who's not responding? I'm Rachel Merriweather. I'm new to the island. I'm a LICSW, new to Massachusetts, new to the island. I am with a company called Effective School Solutions, and I'm contracted into the high school and the middle school to help bring students who've been sent out off island, out of district, to have their educational needs met, to bring them back, and then to interfere with the trajectory of those who look like they may be facing being sent to an alternative placement. And then I have a small practice on the side. So one of the things, being new to the island and trying to wrap my mind around this by way of Philadelphia, New Orleans, and Chicago, so obviously very different environment, is one of the issues that I've been dealing with is students. So my youngest is 6th grade, and then I have, I think my oldest is 11th grade right now. Students who are having this, they're not homicidal or suicidal, right? So they don't necessarily require or qualify for that type of hospitalization. But had I different resources, I would be really leaning on a PHP or an IOP setting if I could. But right now I'm finding a lot of ways to keep them out of inappropriate hospitalization, but get them the response that they need. And I've had some recent success with Fairwinds answering my call and jumping on it and helping me out right away. But I'm wondering, you know, and this may have been covered, I apologize being so new to this area, but is there some sort of discussion about creating that type of middle ground environment that looks like or mirrors a Nantucket version of PHP or IOP?
That's a great question. So there isn't a requirement with the Community Behavioral Health Center to do day treatment or IOP as a specific function. Some of the what are called CCBHCs, the Certified Behavioral Health Centers that are federally supported, have that standard built into it. So you might be familiar with some of those. The Massachusetts supported state CBHC, Community Behavioral Health Center, doesn't have that federal requirement in it. What we do have, though, and it is definitely a part of the shifting landscape here in Massachusetts, some of the youth, the adolescent partial hospital programs have virtual capacity now where they didn't before. You often had to go to the physical location to get that level of service. Many of them are still operating with hybrid capacity. So it's actually more accessible now from Nantucket And if you would like a list of those programs, I could get you that. So I could get our youth division to generate a list for you.
That would be really helpful. That'd be really critical to advancing some of these students don't need to be hospitalized for long term. They don't need a 24/7 bed, and keeping them in the community is very critical to their continued care. So this is kind of the piece I'm missing. So that'd be great. Thank you.
Absolutely happy to do that. And then the other point I just want to reflect on, which is a newer part that will come with the reforms that are in the roadmap, which doesn't exist here in Massachusetts yet, are crisis beds for youth. So that in-between stage of you don't need inpatient, you might just need a very brief supportive environment and not lose long periods of time. And so that's where that will become part of the service delivery system going forward.
That's fantastic. Absolutely. Thank you. That's great. Thank you.
Chris?
Yeah, sorry if I missed it in your introductory comments. Did you mention the time frame when the details would be forthcoming, that some of the questions that Brooke Moore asked?
That is the $1 million question, isn't it?
Okay.
The best answer I can give you without breaking any procurement laws is coming soon.
Okay, thank you.
Brooke?
And where will it be available when it comes? How do we find it?
I can assure you links will be going everywhere.
Okay.
The bid will be publicly posted.
Okay. So there will be a bid packet. Okay.
Yes.
Thanks.
Sure. Yes. These will be contracted, so they will have a bidding process. Are there any other questions or comments? Brooke, what part does the local hospital, I mean, we're trying to eliminate acute care and emergency room as much as possible, but what do you anticipate the local hospital's part in this being on, like, the Cape and Islands? I think that's an important question. And it also, again, may look a little bit different by regions, because community hospitals in some regions have much more presence or depth of inreach within certain communities, depending on the other resources around them. So in a smaller place like Nantucket, where primary care may be delivered through the community hospital, there could be some, like I said, some of that investment around the integrated teams that looks a little bit different than it does today. There's also an important piece that I had mentioned about the community health centers. So there are community health centers that will also receive the benefit of certain investments to build out and develop their capacity. The other part that I wanted to highlight is urgent care will be possible to deliver in other settings as well. So there will be opportunities for existing clinics that may just want to do the urgent care part, to do just that piece. If they may not have a robust enough network to do the full CBHC, there will still be opportunities for them to enhance the capacity through urgent care as well. Well, I'm a big fan of the community health center. We have
some on the Cape, and the one in Mashpee, the Community Health Center in Mashpee, is absolutely super. It does have some mental health services incorporated with the primary care. And I mean, trying to put it all in one, I think, is ideal. I don't know how much that'll happen, but it's kind of one stop. They have dental, in addition to a pretty full range of primary care. And then they do, as I said, have a mental health and addiction piece too.
Any other questions?
Well, if there are no other questions, then I'm going to say thank you again for your time and your explanations. And as you said, there are things you can't specifically reveal right now, but we're waiting to hear that what's going to happen soon, so that we can consider this and incorporate this into our planning for Nantucket, because our goal is to provide a continuum of care in mental health and to eliminate the many gaps that were identified when the assessment was done. So we'll be looking forward to where the state is going with all these things, so that we can integrate wherever we can. And as you know, Nantucket's a very special but challenging place in many ways. And what's working for everybody else may not necessarily work on Nantucket, and we may have to adapt some. So if there's no other questions, I'm just going to say thank you very much. If there are other questions, please jump in.
Jackie, I was just going to reiterate, this is Deborah Demuth. I'm the interim center director here at Vaccination in Cape Cod and the Islands, and that looking at the behavioral assessment that Nantucket did, I think there's such nice synergy with this roadmap. And it's going to be very interesting to see how it all comes to fruition. And Buddy and I will certainly make sure we keep Nantucket, up to speed on what's going on in the process, and keeping your objectives and needs up front. So thank you.
Well, thank you all. I really appreciate the opportunity to connect in with all of you, and I will forward that list of partials. I'll get right on that as well. Who should I? Actually, I'm not sure who I should send it to now that I'm saying this out loud. I don't have, I have Jackie and Sue's contact, but I don't have yours, Rachel.
I can get it through the organization if you think it'd be useful as a whole to the organization. I can get it through there. Otherwise, it's what you see on the screen. It's you can send it to the school. It's the Merriweather R. I'm Rachel Merriweather at NPS.
And Brooke, if you'd like, you can send it to me.
Yeah.
And I can make sure the whole group gets it as well.
Oh, perfect. Thank you, Deb.
Thank you.
I appreciate that. Thank you. I will do exactly that. All right. Well, have a terrific rest of your day, and thanks so much.
Well, thank you again.
Take care.
All right. This is the time that we do announcements, and I know that Suzanne has some, and I'm sure some of the rest of you do. What's coming up as we go into the new year, and where we are at on Nantucket as we move forward. Suzanne, what's happening with your part of NAMI?
I'll be sending a flyer out to the group next week with all the contact information and the dates and times. But starting the 4th Thursday of every month, so the first one would be December 23rd, is a family and friends support group for those with loved ones or friends with borderline personality disorder. We're going to share resources. We're going to discuss what's working and what isn't working, and taking care of our loved ones and ourselves. There's also, starting in January, There'll be a 3-part series, Sober Curious, exploring your relationship with alcohol. It's not designed to, it's not an AA program, but for those who either might choose to temporarily or permanently stop drinking or drink with intention and just explore their relationship with that, what they're feeling. There's also, starting January 11th, a Family Connections program, which is a 12-week education, skills training, and support group for those supporting someone with borderline personality disorder. I'll be one of 3 teachers in that program, and that will be Tuesday mornings from 11 to 12:30. And I'll send out a flyer to the group early next week with all that information and where you can sign up or get the Zoom link or more information.
Anyone else?
I have one to announce. Starting Monday and every Monday and Thursday through this winter, there'll be the warming place will open at the Legion Hall on Washington Street. It is for people experiencing homelessness, and it's a place to come in from 9 to 1 every day, or again, Monday and Thursdays. We'll have breakfast and lunch provided, and they can hang out. We'll have volunteers, so people can come in and chat, play games, read a book, lay down and sleep if they need a safe place to rest. Just a way to show folks that we see them, and while we haven't figured out homelessness on Nantucket, at least we're starting to do something. So please send people that way. And I want to make a huge thank you to the Community Foundation, who is supporting this effort, Cape Cod 5. I think we just got something from Rockland Trust, and a number of private citizens have donated. So I'm really grateful, and I'm really excited to be part of it. I'll be there Monday morning.
Sue, do the people who participate in the program, not the volunteers, do they have to be vaccinated?
Yes, we're asking proof of vaccination. It can be a picture on a phone. It can be the card itself. They have to have at least 2 shots. And we'll be checking and logging it so that if they show us once, we'll know. Jericho,
just on that, if you do have anyone who is there and does not have a first and second dose, let me know. We can sort that out.
Awesome, thank you. I knew there was a loop to close there. So yes, and if we find people who say they're vaccinated but don't have their card, I will be reaching out to Jericho also, because we want people to come in. We really, really want people to come in.
Sue, could I get you to send me something on that I can give to the officers and let them
Absolutely.
know what's available?
Sure, thank you.
Just so everybody here knows, one of the things that kind of is going to come out, I think, is we had a death here in the island this last weekend. That's been a lot of rumor going around, but essentially certainly we're not through with the investigation yet, and this is preliminary. But what it appears to be is a collision of 3 unfortunate circumstances: homelessness, drug abuse, and mental health issues. The individual died of hypothermia and a combination of drugs. So until we get the final reports, we won't know officially. But it's just, nobody knows where to turn, a lot of people. And what I've identified out of this is people who today are saying, oh, we should have known, or we saw him do this, or we saw him do that. Nobody said anything to anybody. So, the community really needs to learn somehow. We need to be able to educate them that when they see somebody that's not right, not appear to have a home, or not appear to be sick, or they appear sick or disoriented or anything else that's unusual, they need to call. Our objective is not to arrest people for being ill or being sick or being whatever. Our objective is to get people help. And So like I said, it really got brought home this weekend with this case.
Thank you for sharing that, because I wanted to say, and I'll get Brooke and Margaretta, is that I've been getting so many inquiries of people just saying, we have homeless people, and that just shocks me, but clearly people don't know and they don't see. And so anything we can do to raise the attention, because that's when change will happen, is when more people see what's happening.
What a lot of people don't realize on Nantucket is there's many homeless, in terms of homeless by definition, that are living in their work trucks. It's just not apparent. They're living there. This parking lot over here behind me, we actually found the police station. We actually found a work truck there. It had an extension cord running out to the town building, plugged in for power. A whole family was living in the work truck. This is happening every day here in the island, and it's not a surprise because of the cost of housing and for the lack of seasonal housing availability to some extent. People think you only need seasonal housing in the summer. That's not true. There's a lot of these workers that are building all these mega mansions and doing all this remodeling. They're here all year round, and they need housing now, just like they did in July.
Brooke?
Here, Chief. To me, that speaks to the necessity for a single point of entry so that there's a safe place for people to reach out to that isn't necessarily the police department, because there are reasons why people don't reach out to the various points of entry we have. And so as a community, I think that's our first priority, is to set up a single point of entry so that whether you are in need yourself or of someone in need, you have a place to go to find resources for people and ask questions about what should we do in this circumstance, that we have an opportunity to care for one another.
Thank you. Margaretta?
Yeah, I just had a quick question for Chief Pittman, because I think there may be some misinformation or misunderstanding in the community about the police's role with mental health calls, because I think we've all been hearing about kind of a statewide or even a national directive that mental health calls really are not the purview of police departments, and that is of some concern. You may want to go into detail, but currently is the policy to respond to all, whether it's mental health or whether it's a violent action or whether it's a overdose or what, that's the current policy. Do you think that might change based on new rules and regulations coming down the pike?
So yeah, we respond to everything that comes in. There are some cases, and I think there will be some changes coming. There are some situations that it might be more appropriate, rather than a police officer responding to, might be more appropriate to dispatch a medic unit, like an ambulance or something. Unfortunately, they're as stretched and limited in staffing as we are. So, it oftentimes takes longer. And one of the reasons the police are there first is because we're out there and everything. But what's happening statewide level is there's a commission that was created by the police reform bill that was the legislature dictated that a commission be appointed and review law enforcement response to behavioral health issues and come out with guidelines and recommendations, if not even regulations, dealing with that. And the consensus amongst the police chiefs is we're pretty much, the objective is going to be to pretty much make it so law enforcement doesn't get involved in behavioral health issues unless there's a known danger, which I don't know how you know that all the time. We all know how volatile these situations can be. That being said, I saw a statistic one time, and I can't guarantee I'm 100% accurate on this, but something to the effect of a situation that becomes volatile, if you send a police officer to it, armed police officer in uniform, there's a 60% greater chance that it'll become volatile than had a trained social worker or behavioral health specialist went. So, you know, I would be one of the first police chiefs to say, if I could figure a way to put some behavioral health responders in this department or in the town somehow as kind of a third wing of our public safety response, I think it'd be a great idea. I say that knowing that we can't house them, we can't, you know, everything else, all the other problems we got trying to hire staff. So if that wasn't an issue, I would be moving ahead. I probably would have been one of the first chiefs in Massachusetts to do it. As it is, I'm watching other departments do it and have some successes and some not successes, but we're all learning how to do it. So I'm willing to do anything different. We just got to understand there's a lot of barriers and issues that we got to get over, but I think we can somehow.
Thank you.
Anyone else, anything for discussion? We have a few minutes here that.
Just a quick update. It's not specific to behavioral health per se, but it certainly blends in. We just sent out the RFP and information for application for the food insecurity grant yesterday to all of our local nonprofits. So here we go. The games will begin, and I'm really looking forward to seeing some of the creative options that our community comes up with as to how we can better sustain our community, better, you know, systematic change. We're not looking, and I've said this a million times, and I'll keep saying it, we're not looking just to feed more people over the next 18 months. We are looking to affect systematic change in the delivery of food systems. And this is a $1.85 million that is coming to Nantucket, and it's going to make a change, and we're going to make sure it makes a change. So it's out there, bring it on. Applications are due the 15th of July, I think. And that's a rolling target. That's kind of we certainly would not accept an application that comes in after that, but that's just, we want to see what's in the door by the middle of July so we can kind of do some planning for 2022, because our goal is to get the majority of that money out in 2022.
Did you mean January or July?
Did I say, no, January.
Okay.
Did I say July? Wishful thinking, sorry. No. January 14th, I think it's the 14th or 15th. I just sent it yesterday. Sorry, I should know that. Middle of January.
Jericho, you can go ahead.
This is not exactly on target for behavioral health, although it is tangentially related. I'm just going to use this opportunity, as there's a lot of people who have wide communications networks here. On December 18th, the Saturday after this coming one, there is a open for all walk-in vaccine clinic for first, second, thirds between 5 and 17-year-olds are also accepted. It's going to be at the elementary school's cafeteria between 9 and 2. I don't know if the communication's gone wide on that yet, but it is most likely going to be the most effective way for anyone who does not have an appointment now to get a booster, as well as please make sure you talk to parents who have 5 to 11-year-old children, since this is going to hopefully be the bulk of the pediatric vaccines on the island. So I thought it would be remiss for me to not share that here.
Anything else? Well, we're going to try to continue to use this forum to bring people from the outside that maybe a lot of people on Nantucket don't know as well in front of you, because an awful lot of decisions are going to have to be made as we go forward on the development of our Continuum of Care project. Some of the people that we have in mind, we need to get VinFen, and I've made contact with the supervisor of VinFen, the whole area supervisor, and because VinFen is the one that DMH contracts an awful lot of their community services too. And that includes community services on Nantucket, and working with several people on the island that seek these services. I think sometimes there's a lot of misunderstanding and maybe they aren't as strong or as they might be. So we'll try to clear that one up, and we'll keep trying to bring in people to make it everyone more aware of what is out there, what's going on in the rest of the state too, so that we can use everything we possibly can to augment what we're trying to do on the island. Any comments, questions? If not, I think we can adjourn.
I will wish everyone a happy holiday season.
Definitely.
Yeah, happy holidays to everybody.
And if I don't see you before, I'll see you in January. Same bat time, same bat channel, right?
Yep. Thank you for your time, and hopefully working together, we can solve some of these issues.